Alrighty, here we go. Hello everyone, and thank you for watching this program on the best personal injury CPT and ICD-10 codes. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, or forwarding of this presentation is illegal. The information in this presentation is for educational purposes. It's not intended to be a substitute for your thorough clinical decision making. It's not intended to be legal advice. Target coding does not engage in providing legal services. CPT is a registered trademark of the AMA. Every attempt has been made to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. A little bit about myself before we get going. My name is Dr. Marty Kotler. I am a chiropractor. I'm also a certified professional compliance officer. I'm a certified billing and coding specialist. My areas of expertise include CPT coding, ICD-10 coding, HCPCS coding, Medicare and HIPAA compliance. I take a little bit of an unconventional approach towards billing and coding because, well, let's look at it this way. Most chiropractors are not certified coders. Most certified coders are not chiropractors. So I could take this unique approach and dig into certain diagnosis codes and feel comfortable recommending what should be done, what shouldn't be done from a clinical approach and from a compliance approach. I've written 10 training manuals on billing and coding and documentation, not only for chiropractors, but for physical therapists and acupuncturists. I write articles to numerous publications and journals. And I'm a guest speaker at many state association conferences nationwide. All right, so let's begin with who can provide services to your personal injury patients. I break it down into two different groups, QHPs, which are qualified healthcare professionals, and clinical staff. So qualified healthcare professionals include chiropractors, medical doctors, PAs, NPs, physical therapists, acupuncturists. QHPs are individuals that are licensed to be able to perform a service, have been trained to be able to perform that service, and can bill those services to insurance companies. Clinical staff, different category. Clinical staff are individuals who have been trained to perform the services. They work under the supervision of a QHP, but would not be able to bill and report the services to a health plan by themselves. So we're talking about PTAs, nurses, certified athletic trainers, rehab techs, PT aides, exercise physiologists. A little bit about supervision. Who needs to be in the room? Who needs to be in the office when the services are provided? Well, personal supervision requires being in the room with the staff member. Direct supervision, somewhere in the office. General supervision, you're available, but not necessarily on premises. For medical doctors working with nurse practitioners, general supervision can take place. With physical therapists and PTAs for certain health plans, not Medicare, general supervision could take place. The most common is direct supervision. Now, a little bit about the state rules regarding supervising and performing services. Some states don't allow CAs to even put a hot pack on a patient. So just do your due diligence. Make sure that you know who could provide services. Check with your state board on staff members on who you can employ and what services they're allowed to perform. Check with all the health plans on supervision requirements prior to billing. Find out who needs to be on premises when the procedures are performed. Okay, now let's begin with some of the most common personal injury ICD-10 codes. Let's begin with sprain and strain. Sprain and strain codes begin with the letter S. S codes. S codes are trauma injury-related codes. And these codes require 7 digits, and the last digit has to be an A, a D, or an S. So S codes always mean there's trauma. We're talking about sprains and strains and fractures and broken bones and concussions and traumatic brain injury, contusions. There are even traumatic subluxation codes. So these codes must be 7 digits, always begin with the letter S and must end with an A, a D, or an S to designate the encounter. So let's begin with the initial encounter. The letter A means initial encounter. So you're going to use this when the patient is receiving active treatment for the condition and you're the first provider the patient visits. Okay, so Mr. Jones is in a car accident. After the car accident, he's got back pain and neck pain, and he comes to see you. You're the first provider that Mr. Jones comes to see for his injury. And you do an exam and do a thorough history and maybe even take x-rays, and you come up with a diagnosis of sprained lumbar ligaments. Use the letter A at the end for the 7th digit extender. Next, D is subsequent encounter. Use this encounter for follow-up visits after the patient has seen another provider. Okay, Mrs. Jones, she's in a car accident. After the car accident, she feels back and neck pain, and she decides to go to her medical doctor. It may be urgent care. Maybe she goes to the emergency room after the car accident. MD says, Mrs. Jones, no fractures, no broken bones. Why don't you go home and rest? Put some ice on your lower back. If you're not better in a few days, then you should go see someone. A few days later, she's not better. She comes to see you. You do a thorough history, exam, maybe you take x-rays. You diagnose her with sprained lumbar ligaments. Use the letter D at the end of the encounter. S for sequela. This means there's a late effect problem has occurred. It's occurred after the original problem came on. So back to Mrs. Jones. She's in a car accident, and let's say she went to the emergency room, and now she's coming to see you, so you're using the letter D. And then after a few weeks, she says, you know what, Dr. Kotler, I've never had pain down my leg. I've never had numbness in my leg. I'm starting to get that type of sensation, weakness, pain in my leg. And now she has some sort of radiculopathy, sciatica, or maybe lumbar radiculopathy. Now, in your opinion, you think this is related to the original injury. That's considered a sequela. So in that case, you would use the letter S on the sprained lumbar ligaments, and then you would use the radiculopathy or the sciatica as the primary diagnosis. A little bit more about sprains and strains. So sprains, you can grade your sprain levels, a grade 1 minor damage, grade 2 partial tearing. If a patient came into your office and you diagnosed the patient with a grade 3 ankle sprain, this patient would not be able to walk. Well, you have tearing of ligaments, significant instability. Strain relates to muscles. Grade 1, minor damage to muscles. Grade 2, more extensive muscle damage. Grade 3, rupture of a muscle, may require surgery. All right, here we go. Here's our first one, cervical sprain. Very common in an auto accident. Sprain and strain. Back in ICD-9, sprain and strain codes were combined into one code. Well, in ICD-10, they've been separated. Sprains and strains are separate codes. So here we have sprained cervical ligaments. That's S13.4. Lumbar strain, so strained lumbar muscles. There's a nice photo of some of the most common muscles of the lumbar region. That's S39.012. And as I mentioned, there are traumatic subluxation codes. They get very level specific, a little bit more complicated to diagnose those codes. And now we have a whole bunch of other very interesting, important diagnosis codes in PI cases. For example, TBI, traumatic brain injury. TBI, traumatic brain injury, it's based on the time the patient loses consciousness. So it's S06.2, depending upon the loss of consciousness, will bring you to the 6th digit, and then the 7th digit has to be an A or D or an S. So loss of consciousness, and that's what you should ask the patient. So Mr. Jones, after the car accident, did you lose consciousness? Yes, I think I blacked out, especially when the airbag went off, and I didn't know where I was for I don't know, it seemed like forever, but it was probably just a couple of minutes where I was out of it. Okay, so that's, without loss of consciousness or with loss of consciousness, but less than 30 minutes. Concussion, also very important. Make sure you know the difference between diagnosing TBI versus concussion. Concussion, same thing. It's up to the amount of time the patient loses consciousness. There are a few examples there. Headaches, very common headaches. I'm going to give you a whole bunch of headaches, not only the traumatic headaches. Yeah, there's migraine headaches, tension headaches. So, patient might come in and complain. These aren't necessarily injury-related or PI migraine headaches, but I thought I'd share them with you anyway. So when it comes to migraine headaches, you're going to have choices with aura, without aura, intractable, not intractable, with status migrainosis, without status migrainosis. So hopefully you understand these terms. Aura, what is aura? So Mrs. Smith comes in and she says, hey, Dr. Kotler, I suffer from migraine headaches. I'll oftentimes say, okay, before the headache even comes on, do you have that perceptual disturbance, like you have confusing thoughts? Some patients go, yeah, Dr. Kotler, how did you know that? I can tell the headache's coming on before it even comes on. I see strange lights. I, have unpleasant smells. So that would be with aura. Another important question I recommend you ask is, okay, Mr. Smith, when you get your migraine headaches, what do you do for them? And some patients would say, Dr. Kotler, I've tried everything. I've tried medication, over-the-counter, prescription. I've tried yoga, acupuncture. Nothing helps. That's considered intractable, hard to control, does not respond to conventional treatment. And status migrainosis, that affects only about 1% of migraine sufferers. The headache lasts for more than 3 days. The patient could become dehydrated, could be vomiting, may need to be hospitalized and put on IV medication. And then we have tension headaches, intractable, not intractable, periodic headaches, menstrual headaches, cluster headaches, drug-induced headaches, thunderclap headaches. You ever hear that? Thunderclap headache? That's a severe headache that comes on suddenly. G4453. Headaches associated with sexual activity. Cough headache. Patients have said to me, Dr. Kotler, I coughed and my headache came on. I was doing fine. I sneezed, a bowel movement. I was laughing or coughing or blowing my nose. Yeah, headache came on suddenly. It's G4483. Headaches associated with menopause. Facial pain headache. Okay, so here these post-traumatic headaches are more in line with PI injuries. You have acute post-traumatic headaches, intractable, not intractable, chronic post-traumatic headaches, G44321, intractable, 329, not intractable. So what determines acute versus chronic? It's a good question, right? Which one would you use on a patient? Well, the standard way to do this is it's the amount of time the patient is suffering from the condition. This works with regular insurance too. Aetna, Cigna, United Healthcare, when they talk about paying for certain conditions, as long as it's chronic. Certain insurance companies, they'll pay for a TENS machine as long as the pain is chronic. So what is that threshold? It's 3 months. If the patient has had pain for 3 or more months, you can give it a chronic label. So Mr. Jones comes into your office, is just in a car accident. After the car accident is feeling headaches, or even a couple of weeks after the car accident develops headaches, you go with acute post-traumatic headache. Here are the regular subluxation codes, the M99 codes. And then we have neck pain and thoracic pain, basic pain codes, muscle spasm codes, very important PI cases to designate and document all these diagnosis codes. How about this? What's the difference between a disc disorder and a disc displacement? Take a look at the screen here. You see cervical disc disorder, cervical disc displacement. What's the difference? Well, disc disorder means that there is nerve root compression causing radicular pain. Cervical disc displacement, in this example here, without any radiating pain. The pain is staying local, and there's no myelopathy, which is cord compression. So make sure you know the difference. You want to use the most appropriate diagnosis codes. You want to use codes to the highest degree of specificity, especially in a PI case, because there's a lot to a PI case, versus a regular patient. A regular Medicare patient comes in, or a regular United Healthcare patient comes in for neck pain and back pain. It's different. It's a different dynamic than a patient that's been in a car accident. One of the reasons is we have a patient that could be suing an insurance company. Another dynamic here is that there's an attorney involved, and the attorney is leaning on you to come up with certain diagnosis codes to help substantiate what's going on. So you always want a code to the highest degree of specificity. Don't diagnose a patient with myelopathy if you don't know for sure that the patient has that. And with these disc disorder and disc displacement codes, in my opinion, you must have some sort of advanced imaging. Now, a little bit about radiculopathy. With radiculopathy, you don't necessarily need advanced imaging. Here are a couple of examples: cervical radiculopathy, lumbar radiculopathy. But how do you justify it? I've been, concentrating here. How do you justify your diagnosis codes? For example, a patient comes in with an SI joint problem, and you diagnose the patient with sacroiliac sprain or sacroiliac subluxation. Something's going on with the SI joint, and now you're questioned. So, Dr. Kotler, how did you come up with this sacroiliac joint problem? Good way to respond is, well, subjectively, the patient had pain in the SI joint. Sitting increased the pain. These are classic signs of an SI joint problem. I did some orthopedic tests, Yeoman's, Ganslin's. Those are the gold standard tests for an SI joint problem. If you're going to diagnose a patient with an SI joint problem, please, I encourage you to do Yeoman's, Ganslin's, do a couple of orthopedic tests. Chiro test, there was tenderness upon palpation to the SI joint. There was some hypomobility, subluxation. There was muscle spasm around the area. So that's how you justify your diagnosis codes. Again here, Dr. Kotler, you diagnosed the patient with cervical radiculopathy. Tell me, how did you come up with that? You may be faced with this if you're dealing in a managed care plan. You might call the case manager and have a conversation, and they may ask, hey, Dr. Kotler, how'd you come up with cervical radiculopathy? Have a good answer. You don't want to look silly. You don't want to be caught off guard. You don't want surprises. Be prepared. Well, the patient came in, had pain in the neck radiating into the right arm. I did some Jackson compression. I did spurling. I checked reflexes. There was some myotomal weakness. There was limited range of motion. There were subluxations. Beautiful answer. Perfect. That's the way to do it. Oh, this is a page out of a book that I would recommend every chiropractic practice have. There's a section of this book that I'm referring to. It's called The Book on the Best Chiropractic ICD-10 and CPT Codes to Improve Reimbursement. There's one section in the book that gives about 25 of the most common chiropractic diagnosis codes, and then the subjective findings, the ortho tests, neuro tests, chiro tests, to help substantiate the code. You see, here's the cervical radiculopathy. Hey, cervical brachial syndrome. How'd you come up with that? Oh, we did Wright's, we did Adson's. There was some diminished sensation, forward head posture, rounded shoulders, scapular winging. Yeah, this is the book. It's an excellent book. It's a very good book. How do I know that? I wrote it. Yes, it's a really good book. Hopefully there'll be a movie one day. So yeah, if you want more information on this book, let us know. Next, ligament laxity. Very common in PI cases, disorder of ligament M24.28. Cervical kyphosis. We're talking about not only has the normal cervical lordotic curve have become reduced, it's now going the opposite way. That's M4292. Sleep disorder. I've had many patients say, hey, Dr. Kotler, you know what? Before the accident, no issue sleeping. Ever since the auto accident, I'm tossing and turning. I can't get comfortable. Every hour or so, I'm up. I can't sleep through the night anymore. G47.9. Now, when I say, personal injury diagnosis, it's not always a car accident. You could have a patient come into your office there, let's say on vacation, and they're in the lobby of the hotel and they slip on the floor and they, injure themselves. Personal injury is not always an automobile accident. It is, in most cases, in a typical chiropractic practice, but doesn't have to be auto-related. Depression, anxiety, very important to diagnose these types of conditions that are loss. The patient says, ever since the accident, I just have anxiety. I've never had this before. The patient is losing loss of enjoyment of life. Just, let's say I've had patients say, you know what, Dr. Kotler, normally every Friday night I go to the movies with my wife. Ever since the car accident, I just don't feel like going anymore. It's not like the patient can't physically make it to the movies. Just don't have that desire anymore. Ringing in the ears, dizziness. There's a few more. Jaw pain, contusion of the head, nausea, pins and needles, abnormal posture, muscle weakness, contusion of the front thorax. How would that happen? Seatbelt. Shoulder swelling, knee contusion, lack of energy. And all of these ICD-10 codes are in the book. Now, let's talk about a few of the most common procedures, therapeutic procedures specifically. One-on-one patient contact. These are time-based codes, each 15 minutes. Therapeutic exercises. Very common code. This should be used to develop strength, endurance, range of motion, flexibility. That's what SURF is. SURF is an acronym for strength, endurance, range of motion, flexibility. It's an active procedure. The patient must be doing some sort of bending and weightlifting and doing something. Balls, bands, tubes. This is an excellent rehab. This is a rehab equipment from foot levelers. Yes, people think of foot levelers, oh, they just sell orthotics for the feet, foot insert. No, they have great rehab equipment and great pillows. Yeah, they have the Baxis and the Nexus. Very easy to get going. I love those neck isometric exercises. So easy to do and put together in your practice. Next code is NMR. It's used for re-education of movement, balance, kinesthetic sense. You always want to check with the carriers you're billing. Make sure that these are payable. This year, 97112, 124, and 530 went up in value. Therapeutic exercises and manual therapy went down in value. So you might see a change in the fees in which you get paid for these codes. And if anybody wants a free fee schedule evaluation, let us know. We do that here at Target Coding all the time. Manual therapy. This is a passive therapy. Very different than therapeutic exercises. Patient is getting some soft tissue mobilization, maybe myofascial release, manual lymphatic drainage, manual traction, not mechanical traction. One of the problems with this code is there's a CCI edit. That stands for Correct Coding Initiative. Not supposed to do this service in the same anatomic site as an adjustment. Isn't that silly? Yeah, it is. But these are the rules. I just explain them. I don't make them. So if you're going to bill manual therapy on the same day as a chiropractic adjustment, you need to use the 5-9 modifier, separate site, separate diagnosis. And remember, it's passive. Manual therapy is a passive procedure. Therapeutic activities. A lot of people call this the ING code because you have to improve, or the patient has a problem with bending, lifting, carrying, reaching, throwing, and your activities that you're doing with the patient in the office is directed towards improving that functional performance. Now, sometimes you're dealing with a PIP case and the PIP benefits get exhausted, and then the attorney or the patient go, why don't you bill Medicare? This is a Medicare patient that was in an accident. Okay, so how would you do that? Box 10. Is patient's condition related to employment? No. Auto accident? Yes. You must fully disclose this information to Medicare. Otherwise, it could be considered a false claim. If you get paid, you could have penalties and have issues. It's happened. Don't mess around with this. If the patient's in an auto accident, when you're submitting the claim, you must check yes to 10B. Medicare needs to know. When you're filling out the claim in box 11D, remember, this is a claim going to Medicare. The question is there another health plan? Yes. If you answer yes, you have to fill out 9, 9A, 9D, letting Medicare know, yes, Michael has State Farm. Medicare says you must bill everyone else before you bill us. All right, let me just close with my 9-step action plan. Step 1. Now, this is a compliance action plan. Compliance as it relates to billing, coding, documentation, Medicare, HIPAA. Here's my 9-step compliance plan. Step 1, get proactive. Step 2, review all new patient paperwork before you actually go into the room to see the patient. Step 3, make sure the patient has filled out all the forms and signed them. Your review of systems form, your assignment of benefits, your financial policies, your informed consent, your letters of protection, your liens, your HIPAA notice. Step 4, review the policies from all the insurance companies you bill, especially the ones that you bill the most. Step 5, understand the what and the why. What is what you're doing? Those are your CPT codes. Why is your ICD-10 codes. That's why you're doing it. Make sure they're correct and justify medical necessity, or else you'll have to give money back. For example, you'll get audited if you're billing 97110 and the patient does not display any type of functional deficit like range of motion. Step 6, do a self-test on your SOAP notes. Make sure you know what to look for per insurance company. Medicare requires your SOAP notes have information that Aetna doesn't. Aetna wants information in the SOAP notes that United Healthcare doesn't necessarily need. Your PI SOAP notes are different than your Medicare SOAP notes. Step 7, find out what a medically necessary SOAP note looks like. Don't assume yours is good. Always be looking to improve. Even LeBron James, the greatest basketball player in the world, has a coach. Yes, I have a coach. If you don't have a coach, you're missing out on some possible abilities to make more money. You know, it doesn't matter if you're all insurance or all cash. You want to make sure you're complying. You want to make sure you're billing properly. You want to maximize reimbursement. You want to make sure you're not leaving money on the table. Find out what an insurance company billing compliance plan looks like and implement it as soon as possible. Insurance companies know that when they do an audit, they're going to make money. They're going to get their money back. A good source told me that every dollar an insurance company spends on audits, they get back $14 to $17. Step 8, put together a simple billing policy manual that explains what you do and why you do it. Example, explain if you adjust full spine, even though the patient only came in with neck pain, you're only going to bill 98940, but your notes are going to show that you adjusted the thoracic, the lumbars. If you do activator, you might be adjusting the knee and the ankle. Explain why you do that. Take a look at your fee schedule. You're billing your PI cases $250 a visit, and then a cash patient comes in and you're doing the same thing for $50? Not okay. And step 9, conduct regular staff meetings, specifically with staff members that do your billing, and especially to the insurance companies that pay you the most. I call it the 35% rule. If you're collecting more than 35% of your income from one particular carrier, do a spot check on that. Check to make sure you are doing what they expect you to do. Also, if you're using a billing company, check them out too. Make sure that they are billing what you have told them to bill. I've recently had 2 nightmare situations. 2 doctors have contacted me that said they're being audited. And once they realized why they were being audited, it was the billing company that was adding units, modifiers, codes the doctor didn't even know until the insurance company came knocking on the door. So do this so you could SWAN. That's my favorite acronym. SWAN. Anybody know what SWAN means? It means sleep well at night. All right, just a few closing comments. Please check with all the plans you bill prior to submitting claims. Can't guarantee this information is going to guarantee payment from any insurance company or patient. Rules change all the time. Do your best. Stay on top of these changes. Attend seminars, webinars. Join your state associations, your national associations. Here's my contact information. You could email me directly, Dr. Kotler at targetcoding.com. Website, targetcoding.com. There's our telephone number, our HIPAA secure fax number. We're on all social media platforms. Follow us on Instagram and Twitter. Like us on Facebook. We have a YouTube channel. We have this particular webinar. If you liked it and you want to watch it again, go to our YouTube channel. Tomorrow, it should be uploaded by then. If you have a staff member or another healthcare provider in the office that couldn't make it to this presentation, the live presentation, have them go to our YouTube channel and watch this presentation. And besides these webinars, we do seminars. We sell videos. We do on-site consulting. We have membership programs. You could even hire us for as little as an hour if you'd like. We have a chiropractic logs, forms, and templates package. We do HIPAA compliance programs, Medicare compliance programs. Yeah, here's our chiropractic, Medicare, and HIPAA forms, logs, and templates package. You get 75 customizable forms. Not only chiro, but PT, acupuncture, Medicare, HIPAA. There's a list of the forms right there. We have them categorize them for new patients. We give you a new patient health history questionnaire, review of systems, authorization for assignment and release. You know, that's boxes 12 and 13 on your 1500 form. We have liens, letters of protection. We have PI, initial reports, interim reports, PI final reports, radiology reports, sample treatment plans for ASH re-exam for medical necessity tier 3, a whole bunch of different sample soap notes. We have sample soap notes for PI, massage, wellness, letters of medical necessity, appeals. Many doctors get denied if they do a re-exam and an adjustment on the same day. We have a great appeal letter for that. Getting denied for your 97140 on the same day as an adjustment. Massage in the same region as an adjustment. We have an appeal letter for that. And you get 23 HIPAA forms with this package. And here's the book that I mentioned earlier. If you order today, we're going to be waiving the shipping and handling fee. There's a section on frequently asked questions. Cheat sheets, great cheat sheets. We have them for PI. We show you which codes paid the most. Here's our product order form. I think we have about 14 videos. We have a section of videos that are $129, $149, $169, and then there are books and forms. Oh, we offer billing and coding policy manuals based on the 7 essentials. So you may be interested in that. There's some sample policies, doing internal reviews. If you see Medicare patients, you should be entering the names of all the the providers and staff members that have anything to do with Medicare billing and coding. Enter their names into the exclusions list. Make sure they're not excluded. If they're on the list, don't let them touch Medicare patients. Staff training. Yeah, here's our billing and coding compliance manual. You get customizable billing and coding policies and procedures, training logs, forms. Yes, very good. And we do them for acupuncture. We are now approved for PDA points. Those of you that are acupuncturists, you know what I'm talking about. We are approved to provide PDA points for our acupuncture clients. You need 60 points every 2 years. So we are authorized to do seminars so you can get PDA points. Here's our Medicare compliance manual. Also, we customize a Medicare compliance manual for your practice, specifically as it relates to the OIG, policies and procedures personalized for your practice. Don't give away free services to Medicare patients. Just saw an OIG bulletin came out, chiropractor giving away free electrical stim to the Medicare patients, $80,000 fine. HIPAA, if you're a covered entity, HIPAA is mandatory. A lot of people don't think this is important. It is more than ever now. HIPAA fines and penalties and breaches are occurring at an alarming rate because of all the cyber criminal activity. So if you're now, how do you know you're a covered entity? If you bill insurance, you're a covered entity. If you receive payment from insurance companies, you're a covered entity. If you submit claims electronically, you're a covered entity. So we have a HIPAA compliance program, and it's based on the amount of employees you have. We offer memberships. This is our base membership, $99 a month. You could stop at any time, no contract, month to month. The best part about this is you could attend our paid live webinars. This was a free webinar. Later today, we're doing a webinar on chiropractic treatment plans. It's approved for continuing education credits in about 30 states. If you're a member, it's free. You can get free CE credits with our memberships. And we do seminars and webinars. Oh, we have a DC Acu PT Integration Expansion Seminar coming up on August 11th in Newark. We have a physical therapy webinar coming up and an acupuncture webinar coming up. So again, I want to thank everybody for attending. I hope you learned a lot. Let's go take a look and see what questions have come in.